Our next presenter is Carl Stecker to speak about on the topic adding to the HIV testing services toolkit, caregiver-assisted oral HIV screening for children 18 months to 14 years in Uganda and Zambia. Welcome.
Thank you. Today is Thursday in Black, towards a world without rape and violence. Jeudi en Noir, vers un monde sans viol et violence. I dress in black every Thursday to remind myself and others of this nearly 25-year awareness-raising campaign out of South Africa. Thank you for the opportunity to present the results of the caregiver-assisted oral fluid-based HIV screening of children studies in Uganda and Zambia. I have no relevant commercial or financial conflicts of interest. According to UNAIDS 2018 estimates, nearly 59,000 children living with HIV in Uganda and Zambia were not yet on ART as the study protocol was being prepared. Testing children is challenging, first because they are dependent on their parents or caregivers to bring them somewhere in order for testing to take place, and second, because parent caregivers often face multiple barriers that limit their ability to get their children tested. The purpose of the studies was to evaluate the acceptability, feasibility, and effectiveness of caregiver-assisted oral HIV screening of children. The results of the studies were intended to support expanded access to HIV testing and treatment services for children, to explore this innovative testing modality which has potential to improve identification of undiagnosed children, and to expand WHO guidelines to include caregiver-administered HIV self-testing for their own children. Regarding acceptability, we looked at whether caregivers would accept to do oral screening of their own children. For feasibility, we wanted to know if caregivers found the screening kit easy or hard to use, whether they needed additional assistance to administer it, and if there were any resulting adverse events or social harms. To estimate effectiveness, we looked at testing yield, the proportion of kits offered and then actually used for testing their children, the proportion of children who completed confirmatory testing, and how soon after a reactive oral screening result, and the proportion of children subsequently linked to ART and how quickly they were linked to ART. The secondary objectives looked at the costing of oral HIV screening compared to standard of care blood-based testing at facility, and to look for any social harms to children or their caregivers related to the use of oral HIV screening and the post-test results. Both studies used a cross-sectional, proportional to population cluster sampling design to select a total of 47 sites, 32 in Uganda and 15 in Zambia. Both studies enrolled index caregivers who were at least 18 years of age, men or women, with eligible children. In Uganda, emancipated minors aged 15 through 17 years were also accepted. Children were eligible if they were 18 months through 14 years of age, with an unknown HIV status, and whose biological mother's HIV status was either positive or unknown, or who was deceased. While Zambia only accepted biological children, Uganda also accepted non-biological children residing in the same household as the caregiver. Otherwise, eligible adult participants were excluded if they answered yes to any of 4 intimate partner violence risk assessment questions. Children were excluded if they did not meet the age criteria or had a known HIV status, positive or negative, or were still breastfeeding, or were less than 3 months since cessation of breastfeeding. Zambia also excluded non-biological children of index caregivers. From February through October of 2021, interested index caregivers from post-test counseling ART or mother-baby clinics were informed about the study and referred to research staff. 3 options to test their children were offered: to take an oral test kit home to screen their own children, to bring their children to the facility for blood-based testing, standard of care, or to have a healthcare worker come to their home to test their eligible children. Those who consented to participate in the study received OraQuick Advanced Rapid HIV Antibody Test Kits to screen their children. Caregivers of children with reactive oral screening results were reminded to bring the children back to the facility for confirmatory testing per respective national guidelines. Those confirmed to be living with HIV were linked to ART. Study registers and a caregiver post-use survey were used to evaluate acceptability, feasibility, and effectiveness. Pediatric HIV self-testing had high acceptability among caregivers who accepted to test their children. Of the 4,059 eligible caregivers, 96.8% accepted to screen their children. Of nearly 7,600 children with oral HIV screening kit, 97.6% completed the oral HIV screening and returned the results to the research staff. Pediatric HIV self-testing had high feasibility. 119 children, or 1.6%, had a reactive oral test kit result, decreasing the need for facility testing by 98.4%. 97.5%, or 116 children, completed blood-based confirmatory testing at the facility, and 59% completed same day, and over 82% within the first week. Pediatric caregiver-assisted HIV self-testing was effective with a high positivity among children receiving confirmatory HIV testing, and high linkage to same-day ART initiation among children confirmed HIV positive. 43 children were confirmed HIV positive, of whom 97.7%, or 42 children, were initiated on ART the same day. Only 0.4% of children reported minor reactions with use of the oral test kit. Uganda surveyed all 2,250 parent caregivers. Zambia did a convenience sample of 469 caregivers. Together, 98% of caregivers surveyed in Uganda reported oral test kit was easy to use, compared to 93% in Zambia. And 97% of surveyed Ugandan caregivers would recommend oral screening of children to other caregivers, compared to 92% in Zambia. In conclusion, we have added to the growing body of evidence on use of caregiver-assisted oral HIV screening of children and suggest that it is acceptable, feasible, and effective for high-risk children who might not otherwise receive HIV testing. We believe it could potentially help to decongest health clinics. Secondly, our findings suggest that policymakers may consider revising guidance to promote caregiver-assisted oral HIV screening of children 18 months through 14 years of age, thus adding one more tool to the toolkit for identifying children living with HIV and expanding community-based pediatric testing options. Through funding from PEPFAR and the Centers for Disease Control, Catholic Relief Services FASTER project catalyzed the HIV response for children and youth in Nigeria, Tanzania, Uganda, and Zambia. We thank both caregivers and children participants in the study, and acknowledge research staff, study site healthcare workers, and partner organizations, especially the Ministries of Health of Uganda and the Ministry of Health of Zambia, and all the co-authors, as well as OraSure Technologies, for donating OraQuick HIV testing kits for the study. For more information on caregiver-assisted oral HIV self-testing, please look for these posters that were on display yesterday and today. And thank you again for the opportunity to present this interesting data to you.
Thank you very much.